president and founder of Dysautonomia International. I'm broadcasting to you from my house in New York. I was a little late to be at the office. I'm really pleased to be joined by Dr. Melissa Kaufman from Vanderbilt University, who I will introduce in a minute. But before I do, I just wanted to give a promo kind of shout out. Today is Giving Tuesday, November 30th, which is one of our biggest fundraising days of the year at Dysautonomia International. So if you haven't seen our social media posts or our email blasts, and you're feeling in the giving spirit, you can donate today through our Facebook fundraiser, and your donation is eligible for triple matching. So Facebook will match up to $2 million in donations today for donations made on our Facebook page. And Dr. Abdullah, who many of you might know from our medical advisory board, as well as the Leday family and King and Spalding law firm, have offered to match up to $50,000 in donations from now until the end of December. So I don't want to, I'm trying not to be too pushy about fundraising, but if anyone's in the mood to give, today is a great day to give because your donation will go even further. With that, I will start off our webinar and introduce Dr. Kaufman. She is a professor and chair of urologic surgery at Vanderbilt Medical Center. She works closely with the Autonomic Dysfunction Center that many of you know about or have maybe seen. And her practice focuses on female and male voiding dysfunction and incontinence, cancer survivorship, pelvic organ prolapse, neurourology, transitional care for congenital urologic conditions, urologic prosthetics, as well as reconstructive surgery for urethral stricture, fistula, and trauma. I think I should get bonus points for pronouncing all of that pretty much correctly.
Perfect.
She's a very, very accomplished urologist and has published some research on autonomic disorders associated urological disorders. And with that, I will pass the mic over to Dr. Kaufman, who you can share your slides.
Well, thank you so much. I appreciate everyone's time this evening, and hopefully we'll have some good back and forth to be able to answer questions that you might have about bladder issues and how it impacts how dysautonomia may impact. These are my disclosures. The only one that's really involved with today's talk is my service on the American Urological Association's Practice Guidelines Committee. We just finished publishing the guidelines that all urologists should utilize for neurogenic lower urinary tract dysfunction. And so many of the things that we'll discuss today are involved in those guidelines, and I'm happy to discuss more with you because it may impact some of the diagnosis and treatment strategies that many of you will encounter. So our objectives today are really to define a little bit about what's normal, like what does the lower urinary tract do, and how are the nervous system pathways modulating urinary function, and how some autonomic disorders may impact that, what we do to diagnose this, and then some treatments that you may encounter with regards to these bladder issues. So what does a bladder do? Well, in essence, in the most basic of terms, it stores urine and then it empties urine. It has a tremendous role, though, with our central nervous system and the peripheral nervous system. And there's a tremendous role also, not just with the functional aspects, but the structural aspects of lower urinary tract anatomy. So just a little bit of anatomy, which many of you may be familiar with, is that the kidneys are up here in the back, well protected by lots of layers surrounding them and up near the rib cage, and they filter the blood and create urine. And of course, this drains down the tubes called ureters, which run between the kidneys and the bladder to store in the bladder. And then the urethra itself is the tube that passes the urine in order to hold it in, and then the sphincter is the muscle that holds it in. Now, there's many different supporting tissues. And of course, this is just a female anatomy, but many different tissues, of course, in men as well that may contribute. And all these work in synergy. So storage has to accommodate the volume of urine that's put in there. And I think many of you know that sometimes that can be quite a profound amount. The idea behind storage of urine is that the bladder has to maintain continence. So it has to contract a sphincter and allow this volume to continuously expand. And it has to do this at very low pressure, because if it holds urine at high pressures, that urine's going to go somewhere. And it can go one of two places. It can either go back up into the kidneys, and those are called the upper tracts, and this can cause kidney damage over time. It also has to be able to drain freely into the bladder, because if there's high pressures in the bladder, even if it's not refluxing back up into those kidneys and it's not draining well, this can also cause renal damage, kidney damage. And it has to give the appropriate sensations of filling. And the bladder is a very, very sophisticated organ for all this. There's many layers to it, and it includes an investment of lots of connective tissue around it. And so sometimes even connective tissue disorders can impact bladder function. Voiding, so the bladder stored the urine, is a very coordinated event. And the key is that you want it under voluntary control, that it can't just occur whenever it wants to, as it did, with a baby. When, as the bladder gets to a particular volume, then it just contracts and empties. So you also have to have a very specialized type of contraction. So it has to be sustained. It has to be of appropriate duration and strength, and a coordinated contraction that will allow complete emptying. If the bladder has a quiver here and a quiver here, it may still be contracting, but it's not going to be sufficient to allow complete emptying. So again, storing urine requires low pressure, no abnormal contractions, and you got to keep it in by closing the sphincter. Emptying of urine requires a coordinated contraction and opening of that sphincter. And here's where we start to get into a lot of the real neurophysiology of how this occurs and why any type of autonomic issue is going to cause significant bladder issues in some instances. So this neurophysiology requires a reflex arc in the sacral spine. It requires an intact thoracolumbar sympathetic system. It requires higher brain centers, the pontine micturition center, that give inhibitory input. And all this has to work on muscles that remain intact for a coordinated sphincter relaxation. So absolutely any insult or injury in any aspect of this system can result in very disorderly storage, very disorderly sensations, and very disorderly voiding reflexes. So I want to give you some information about how, from an autonomic perspective, this actually works. The sympathetic system runs through the lumbar cord to, in the pelvis, a nerve called the hypogastric nerve that branches out into a plexus that innervates all the pelvic organs. So this innervates the bladder neck, the sphincter, and also other aspects of the uterus in women, the rectum in both men and women. So lots of different organs in the pelvis that can be impacted. The neurotransmitter is norepinephrine for the sympathetic system. So in the bladder, it causes the bladder to be quiet. So it wants it to be quiet while it fills, and it keeps the sphincter tight. So it makes the bladder quiet, keeps the sphincter tight. The parasympathetic system is required in order for the bladder to actually contract. So this goes through the sacral cord and to a nerve called the pelvic nerve, again, branching out into a plexus and into the bladder walls. its neurotransmitter is acetylcholine. And this causes the bladder to contract and relaxes the sphincter. But of course, you also have to have the voluntary and somatic, the skeletal muscle system. And this goes through an onus nucleus in the ventral horn and innervates through a nerve called the pudendal nerve directly into the external urethral sphincter. And it's modulated by acetylcholine as well. Now, some people, and my residents and house staff and fellows included, learn better with pictures. And so I've also added those just to give you an idea of exactly what's happening here. So this is the sympathetic system. And the keys here are that the sympathetic system is required for quiet and adequate storage of urine. So it will, through this hypogastric nerve, through the T10 and L2, it will contract the urethra here, and it'll relax the bladder. And I've actually put the types of receptors here for you to look at, because this comes into play later when we talk about treatment options of exactly which receptors we're trying to target to help the bladder do its job when there's been some disorder of the autonomic system that's resulting in issues with the bladder being able to store urine. There's also activity during bladder filling, very profound activity during multiple areas in the deep brain. So this is not just a thoracolumbar system. It's not just a sacral system, but it requires a coordinated activity in the deep brain that allows the quiescence of the bladder during the filling phases. Now, the parasympathetic system is activated for emptying. And of course, this has to be done under voluntary control. This goes through, again, the pelvic nerves, and this is the M receptor, muscarinic receptor. It will inhibit the urethra and contract the actual detrusor, which is the muscle of the bladder. So again, just for normal bladder function, the parasympathetic system contributes to emptying by contracting the muscle and relaxing the sphincter. The sympathetic system contributes to storage of urine by relaxing the muscle and contracting the sphincter. And the somatic system modulates both. So when the parasympathetic system, when you're ready to empty, it will relax the sphincter. And when you're ready to store urine, when the sympathetic system is activated, it contracts the external sphincter. Now, obviously, this is an incredibly, incredibly complex system that is much more complex than what we've defined here on these slides. And there are other aspects that may actually contribute. And these include some of the structural aspects of the bladder itself. So the bladder wall has to be able to accommodate and stretch without increasing in pressure. And that's secondary to the actual structure of the bladder. So it's a situation we call compliance. So there should be no change in pressure associated with an increase in volume. So this is the tonal properties of the muscle, along with all the connective tissues and the extracellular matrix surrounding the bladder. It has to do this at an appropriate capacity, and again, has to have appropriate neural control for a coordinated sphincter response. So this reflex, when you feel the need to urinate, there's a stretch receptor in the bladder, and this will give a strong signal that goes all the way, transmits all the way back up to the deep brain that interprets this signal as a need to void. Now, as you might be aware, that can be deferred in many instances for very long periods of time and suppressed. And that's a product of the deep brain signaling. When that finally comes to fruition and you get to a socially appropriate place in order to void, then the sphincter relaxes and the bladder contracts. Obviously, that time frame can be markedly different depending on the insult that has occurred to the structures that are modulating those nerves. So these are sensory nerves that go to the spinal cord. This through some of the pelvic and hypogastric nerves that also feed into the pudendal. And these are sensory nerves that are intact, that need to be intact and separate from all the motor nerves that are actually doing some of the work of keeping things quiet and then contracting the bladder. And when we look at pictures like this, and when I talk to you about, well, this nerve runs here, I wish that it actually looked like that in real life, right? Because this would be something where we could intervene at the level of the nerve and try to mitigate or moderate things. But the fact is that it's incredibly complex. So it may be, this is all the vasculature, and these are all the large fiber nerves that are surrounding the organ that we know is the bladder. There's also invested in this all the connective tissue layers and all the other organs surrounding this. So the situation just increases dramatically. We're to a point where oftentimes I can tell you what we're doing in order to treat these conditions is just mitigating the end product symptoms. We're never, very rarely getting back to the initial insult and being able to identify just the nerve that's being impacted or the set of nerves, or whether this is a central issue that is then impacting the bladder preferentially. So obviously with dysautonomias in the bladder, there's a number of different things that we would consider depending upon what the primary diagnosis is. And sometimes it can be a complete mix of this. In addition to all the things that we know about, like postural orthostatic tachycardia syndrome or multiple sclerosis, multiple system atrophy, there's whole variations on things like spinal cord injury. You know, I see many patients who have spinal strain from lumbar disc disease who end up with the same type of symptoms just from a low back strain in the lumbar spine. Pelvic surgeries, of course, diabetic neuropathy. There's also a whole suite of autoimmune conditions that I see that contribute to many of these same types of issues in the bladder. And the situation is that most of the time, what I see is that there's multiple issues that are superimposed upon each other. And oftentimes it's very difficult to discern which one is the driving factor. And it may have taken 3 or 4 different ones in order to come together to create the situation in the bladder. So although they all contribute, sometimes it's very difficult to discern which one is predominant. And very seldom do we have a way to reverse primary pathology when we're treating bladder symptoms. So one of the most bothersome things that happens to individuals who end up with bladder dysfunction is called urinary incontinence. And this is really a loss of control of the bladder that results in urinary leakage. And there's several different types of urinary leakage, and they can concur concomitantly, but most of the time it is with urgency. And so an urgency is really an overwhelming need to urinate. Even if you just went, you can't hold it long enough sometimes to even reach a bathroom. Patients with urgency and leakage do strategies like bathroom mapping, so you know where the bathrooms are everywhere you go. There may be uses of pads. People will restrict fluids in order to decrease their urgency incontinence. Stress incontinence is really urinary loss during exercise. So coughing, sneezing, laughing, body movements that cause increases in intra-abdominal pressure that doesn't allow the sphincter to hold in the amount of pressure that's being exerted upon it. But many patients have a combination of both, especially patients who've had prior pelvic surgeries, or women who've undergone childbirth. They can have a combination of both of these. And so you add on to this dysautonomia of any type, and you end up with a very profoundly bothersome situation, because it has extraordinary impacts on quality of life. I have seen incontinence socially isolate people. It contributes to depression, distress, to the burden of everyone surrounding you. Of course, there can be true anatomic issues with skin breakdown and sleep disturbance, urinary infection, and other quality of life measures like simply avoiding sexual activity because of fear of urinary incontinence. So it is not a benign situation. And there's actually some data that would suggest that it increases not just a quality of life, but quantity of life as well, that there's real mortality associated with urinary leakage. And the costs are very profound. You know, if you go down that aisle at the grocery store, most of those are not baby diapers. Most of those are actually adult incontinence products. You can get them online. They'll send it to you in a brown box at home. And it exceeds overall cost and exceeds actually the incidence for a lot of other common health conditions. There's estimated, at least just for overactive bladder, to be 37 million patients with urgency urinary incontinence in the United States. And so it's a very, very undertreated condition. And of course, these costs are very profound, not just from a personal perspective, but also from a societal perspective. So the expectations that we have, and we know a little bit about what to expect when we see different types of insults to the bladder. So most of the time, brain lesions will cause overactivity with a coordinated sphincter. So patients will have maintained sensation, but have a lot of bladder overactivity. When we have real spinal cord, complete transection, spinal cord injury, they may have variable overactivity, oftentimes with a closed sphincter. And peripheral lesions, something like in the sacral spine, can cause loss of sensation and motor function. Of course, with certain types of systemic dysautonomias, it could be a combination of all of these. In multiple sclerosis, we'll often see bladder overactivity, sometimes with an uncoordinated sphincter. In Parkinson's and CVA, things that we know are confined to the most part to the upper motor neurons and the central nervous system, can be a combination, but most of the time it's an overactivity of the bladder. And MSA is also an overactivity, but interestingly, it has an open bladder neck. But when the bladder contracts, the bladder neck actually closes. So what I've found also, and this is for many, many different conditions, that sometimes the bladder is a very telling organ. So it will precede diagnosis of many other situations. And certainly I see patients that come to me first because of they're young or they have new onset bladder symptoms, and they end up getting diagnosed with some other type of neurologic disorder or autonomic dysfunction after they've come in just for bladder symptoms. Because obviously when you have a little bit of knowledge about how all this works together, you want to make sure you're ruling out something that needs further evaluation, not just a primary bladder symptom. Things that I find are very common are the urgency, frequency, leakage with urgency, and also retention, where patients feel like they have extreme hesitancy to need to get their urinary stream started. And these are due to a number of different dysfunctions of all those things that we talked about before. So overactive bladder, I've used that term a little bit. It's actually not to be cynical, but it's a little bit of a term that was coined by the pharmaceutical industry when they first started to develop some of the agents they needed. It's not as if they needed a disease in order to develop a drug, but they needed a term that would make it palatable. And it's an easier term, I think, in many instances for everyone to understand. And now it's become common vernacular in the world of urology. But an overactive bladder is really one that's defined by urgency, with or without urgency leakage, but usually with frequency and nocturia. So nocturia is awakening at night in order to urinate. Normal is about twice a night, depending, of course, on your fluid intake, but normal is once to twice a night. But when this becomes bothersome, when it impairs your ability to return to sleep, then it becomes a little pathologic. But the urgency is really the hallmark symptom. And this is that sudden, compelling desire to go, which you really can't defer. And it's due to a failure to store. So the bladder is actually beginning to have muscle contractions or abnormal sensations during the storage phase. So what do? You come to my office and say, these are the types of issues that I've become to develop. So obviously a really good history and physical is critical. Understanding, is there something else that's contributing? And this is where you want to find someone who is facile at understanding how neurologic disorders may impact bladder function. And someone who'll also do an appropriate physical, and that includes a genitourinary exam. So for women, it's a brief pelvic exam. For men, it's an exam of their prostate and of their genitals to make sure that there's nothing else anatomic that could be contributing to these symptoms. Most of the time, you'll undergo a urinalysis. So this is just a dipstick test where you urinate into a cup in the clinic, and we check to make sure there's no other things like an infection, that there's nothing like blood that needs to be addressed. And of course, a good history that's going to help you understand the context of these symptoms and how other conditions that you may have contribute. Other things we consider, and of course in a urology office, we're more adept to do this, include things like a post-void residual. So this is an ultrasound test. We take a small ultrasound, run it over the abdomen to see how much urine is left there, basically. We may ask some symptom questions. I have a lot of different questionnaires that help me help you, because it allows me to see and track over time how well we're doing with our therapies and how bothered you are about particular symptoms and what is the most bothersome thing, because sometimes we have to triage and work on one issue at a time. For really complex situations, and frankly, when I get patients in my clinic who are suffering with dysautonomias, oftentimes I find this is an extraordinarily complex situation on many regards. And instead of simply trialing different things and seeing what works, I want some more objective data before we can come to move together in a shared decision-making process about the next best steps of treatment. Because sometimes even something as benign, seemingly benign, right, as pharmaceutical interventions can have very profound impacts. So we want to make 100% certain that we're treating the right issue at the right time. So we do that often with more invasive, not invasive like something where you have incisions, but things that require catheters and a little bit more time than just urinating into a cup. Things that like urodynamics. So this is a functional test of the urinary tract. Cystoscopy is an anatomic test. And then every once in a while, we may need to have imaging. We may need to have ultrasounds of the kidneys or even CT scans if there's need to evaluate the kidneys, upper tracts, something perhaps for stone disease or issues that may be impacting bladder and renal function. So we wondered with the patients who had a postural orthostatic tachycardia syndrome at our autonomic dysfunction system center. I was seeing a lot of these patients who came to me with bladder symptoms. So we kind of wondered, we went back and said, well, how many of these patients had an issue that was really bothersome? So we just took 32 patients that had come in over a time period and just asked some questions with a validated questionnaire that I give out to all my patients that come to my clinic now. It's an overactive bladder symptom questionnaire. So they either have an uncomfortable urge to urinate, sudden small loss of urine, the nighttime urination. And it's basically a very straightforward questionnaire. And what it turned out that in these patients that were in the autonomic dysfunction center here, almost 70% met criteria for what we would consider clinically significant overactive bladder. That means overactive bladder that needs treatment. These patients were not patients that had come to a urologist. These were just patients that came through the autonomic dysfunction center here at Vanderbilt. And they said that the most bothersome symptom that they had was awakening at night, the nocturia. So again, urodynamics, what does this actually mean? So this is a functional test of the bladder. You come to the clinic, we actually place some small, tiny pediatric catheters into the bladder and one into the vagina or sometimes into the rectum if you're a man. And then we fill the bladder while you're sitting next to the pressure monitors in the computer. And we're looking on the pressure monitors of the computer to try to see what's happening to the bladder during filling. We're asking you questions. What's going on? How is this impacting what you're feeling right now? Is this replicating what happens to you in day-to-day life? And then we also look when you actually urinate. Are you emptying the bladder completely? Do you do it with an abnormal contraction in the muscles surrounding the sphincter that should be relaxing during this time? So we can obtain all this information from a test that is really minimally invasive and takes about a half an hour of time. And then sometimes we'll also perform cystoscopy if there's suspicion that there's something else anatomic that could be also contributing. And this is where we take a small flexible light scope, and it's just the end. It's about the size of a catheter for anybody who's had a catheter before. And it goes into the bladder. And here's the view of the internal walls of the bladder with normal blood vessels. Now, what we find most of the time is a term that's called neurogenic overactivity. That just means it's bladder overactivity due to a relevant neurologic condition of which dysautonomias would be considered. These are involuntary contractions that are provoked during the urodynamics testing. So actual bladder spasms that are occurring during this testing. And oftentimes, this is what's associated. The patient will say, I have the feeling of urinary urgency right now. I've got to go. And it's loss of inhibition of those pathways from the upper motor neurons. So this is an example of a tracing for urodynamics. So this is the pressure catheter that's in the bladder, the blue line. And this is the pressure catheter that's in the rectum, the red line. And it's a subtraction equation because you can imagine as you bear down on the top of your bladder from your abdomen, it creates a little pressure. So what we're really looking at is this line here, this green line. We put some patches to measure pelvic floor activity. So we see what's happening to that sphincter. And this is the flow that comes out. This is the volume of the flow that comes out. And then this is what we actually put into the bladder. So in this individual, they got about 330 cc's of urine in the bladder. But what happened was as we went along here and about 200 cc's. And so if you imagine you're making somewhere around 50 cc's an hour. So this is 3-4 hours worth of urine. They had a tremendous spontaneous abnormal contraction of the bladder that we measure during the urodynamics testing on these pressure monitors. And you can see here, this is reflected as a leak in our flow channel. So this is a detrusor overactivity contraction, an abnormal contraction that will cause overactive bladder symptoms of urgency and frequency. And indeed, when we kept filling, it happened twice. Now, one of the most worrisome things that we're looking for on these tests is what neurologic injury to the bladder can do to the elasticity of the bladder. So when I mentioned before that it has to store urine at low pressures, it's critical for the kidneys and to decrease urinary leakage. And this is just an example of what happens when we have loss of bladder compliance. So again, we're looking at pressure in the bladder here. And as it increases, it continues to increase. It's not like one of those abnormal contractions. This is a continuous increase in pressure. And by the time the patient had a leak, that didn't show up here, but by the time this happened, the pressures were up to 50 centimeters of water pressure. So that's quite a lot of pressure. And this can put significant pressure on the kidneys that won't allow them to drain, and also can cause damage and reflux. And what we look at here is sometimes we'll use contrast and actually look. And what you see here is that this patient, that arrow that I had, the pressure was 51. This patient, it was 57 when they started to leak out this way. So this is the pelvic bone, this is the bladder, and they also refluxed urine up into the kidney. So they are having leakage and kidney damage at the same time. And this is another patient who had, this is where I said the bladder will squeeze, as you see here, but the sphincter muscle remains closed, and you can actually see that indentation. And these are patients that are at risk for kidney damage if these storage pressures are very high, above 40 centimeters of water. And sometimes this was all diagnosed and all defined in spina bifida patients. And so those were children with spina bifida. It's unclear whether this is true for other individuals, but certainly we like to keep pressures low because it can eventually cause damage and can cause issues with leakage. So what do we do for overactive bladder when you get the diagnosis? So first off, of course, behavioral therapies. Sometimes this can be very difficult to adhere to, particularly if you've been told to drink very high quantities of water. But there's other things that can be extraordinary bladder irritants that we can assist with. There are medications, and sometimes we have combined medications. We have minimally invasive therapies, and then surgery, if all else, if we can't find a meaningful solution and it remains bothersome in the end. So some of the first line therapies include not just understanding fluid management, of which many of you do understand, but this would be very difficult if you're being told to ingest large quantities of water. But sometimes there's other fluids that impact bladder function even more. We can do pelvic floor muscle training and bladder training to try to help, even if you do have large quantities of urine created. We want to tailor it to the individual, of course, and just try to make realistic goals based on your other issues that we need to discern. But there's lots of pharmacologic targets that can help. You remember the receptors that I showed you in those earlier pictures? Well, there's ones for this parasympathetic nerve that are based on acetylcholine. Those are the ones that squeeze the bladder. There's ones in the sympathetic nerve that cause the bladder to relax. These are the beta receptors. And then, of course, there's alpha receptors at the urethra. So some of the second line therapies include medications. Some of these are anticholinergic. So the cholinergic system is causing the bladder to contract. So actually suppressing that anticholinergic will cause it to relax. And this is a whole suite of different medications. We also have beta-3 adrenergic agonists, and these cause the bladder to relax during filling. But they have side effects, right? The anticholinergic side effects are not trivial, and they can be dry mouth and constipation that will create a situation where you can no longer take the medication. And in fact, many patients, up to 73%, will discontinue by 12 months because they're not as effective, or they actually have these bothersome side effects. One of the most troublesome ones that has come to light even more profoundly in the last several years is impaired cognitive function. And this may be including long-term dementia. So the only anticholinergic medications that I still currently use are ones that don't cross the blood-brain barrier, and it's one called trospium, and it still has the same other side effects to it, but it doesn't cause cognitive dysfunction. Beta-3 agonists will bind to these receptors in the bladder and help it relax during filling. There's several of these, and one of them can increase blood pressure, which may be good in some instances, but for the most part, these things need to be monitored well. But these don't have some of the other side effects and don't have the cognitive side effects as well, but they can be very expensive agents to obtain in many insurance plans. Other therapies, if medications and behavioral therapies don't work, include modulating the nerves. So basically, we want to find a way to redirect this abnormal signaling that's going into the bladder through the nervous system. And we can do that through the sacral nerve, and we can do it directly through the bladder, the nerves inside the bladder, and the muscle itself. So sacral neuromodulation includes a stimulation of all these different pathways, and it can modulate both voiding and storage. There's several ways to accomplish this, and one of them is a peripheral nerve. So the tibial nerve comes back and communicates up the leg to the nerves that are actually in the sacrum and in the pelvis. And you stimulate, it's very minimally invasive. It's like an acupuncture needle that goes into the leg. It stimulates for once a week for 30 minutes for 12 weeks. However, minimally invasive sometimes means a little bit of minimally effective. The adverse events are very uncommon and mild, but I find that many patients respond somewhat, but it's not much more than medications. But if we need to substitute for medication, this may be a good option. Sacral neuromodulation is a very powerful technique that modulates the reflexes by actually placing a lead. So just like you would have a cardiac pacemaker, as a matter of fact, it's made by the same company. It is a lead device that is implanted into the sacral nerves to control not just urgency frequency, but also urinary retention. It's additionally utilized for bowel incontinence. It's MRI compatible and extraordinarily effective, but it is a surgical procedure to undergo. And then we also use botulinum toxin. This is the world's most powerful neurotoxin, and it blocks release of acetylcholine. So it'll block release of the neurotransmitter that's causing spasticity. It decreases muscle contractions everywhere that is placed, for cosmetic use, for large muscle spasticity, but also in the bladder. So it's a clinic procedure. The bladder's numbed, where you're able to go in with that light scope, just like you saw before, and implant the medication on the back wall of the bladder. The biggest issues with this are elevations of the residual urine that's in the bladder, sometimes necessitating that patients catheterize in order to get their bladder to empty while the Botox is in its maximum effect. And of course, for retention, intermittent catheterization is a very powerful tool. So there's no foreign body that's in the urethra for long periods of time. It allows emptying even when there's poor contraction of the bladder. And there's lots of debate for people who've had to catheterize about, do we reuse catheters? Is there something about the catheters? And it turns out that there's really not one catheter type or technique that's better than another. Many patients will just be able to kind of experiment with things that work for them and come up with one that reduces their incidence of urinary tract infections and is comfortable. And it seems like a very intimidating procedure, but it's one that we can readily teach and that patients will oftentimes, because of the relief that it's providing, especially for someone with retention of urine, can help tremendously. And finally, if none of these things give us the results that we're looking for in a very shared decision-making process, we may go to utilizing an indwelling catheter, one that's put through the abdominal wall called a suprapubic catheter. And in very rare cases, we will actually utilize very complex reconstructive procedures where we're patching bowel onto bladder to increase its capacity and decrease spasticity, or even completely diverting the urine with an ostomy. Again, very rare conditions. So overall, I hope that I've expressed that storage and voiding of urine is a very sophisticated, coordinated neuromuscular event. Sympathetic input controls storage, parasympathetic input controls voiding. We have many therapies, including behavioral therapy, medications, some minimally invasive therapies, as well as surgeries. And so I encourage you, if you're having any types of issues, to find a urologist who has knowledge of the dysautonomias in order to give you appropriate treatment. And I thank you very much, and I look forward to your questions. And I see there's several up here in the chat.
Yeah, I will help us. Thank you so much. That was a great talk. And I know this is a topic that, we actually haven't had any other experts talk on this topic. You've presented on it at our conference one year. And I think that there's not a lot of people that are into this piece of dysautonomia. So we really appreciate this information for our patients. And I know that some of the people listening are actually clinicians too. So I'm sure they appreciate it, even though it's not a CME, it's still good info. Here's a question. Have you had any success with Botox for the bladder to relax and sort of reduce the urgency?
Yes, that's an excellent question. We actually did some of the early clinical trials here for both non-neurogenic and neurogenic botulinum toxin injections to the bladder. And it turns out that there is an incredible amount of success, and including something along the range of you're having leakage already, close to 40% what we would consider a dry rate after Botox injections. The intricacies of doing it include the potential necessity for intermittent catheterization. So we always, if you're spontaneously urinating, we always start with lower doses with the hopes that we will be able to decrease the amount of medication and decrease risk by doing that. But it does wear off. And so it can be a little disconcerting for patients who've gotten to a solution for their problem to then begin having symptoms again. So what we do is we try to only let that happen once. So you find your interval of time. So if you have an injection, you can get a repeat injection as frequently as every 3 months. Sometimes it may be up to 12 or 18 months in between injections. And it's a relatively quick, comfortable procedure for most patients to do in the clinic. So you come in and get your bladder Botox touch-up. But it is markedly successful when managed appropriately to reduce urgency and urgency leakage.
So sort of a similar question maybe, but probably a different answer. Are there treatments for the loss of sensation? If someone can't feel that their bladder is full?
Yeah, that's an excellent question, and one that can be very problematic. And what I find is that oftentimes that sensory loss goes along with what we call non-obstructive urinary retention. So patients who have a sensory loss will oftentimes not get the signaling in order to void, so they retain urine more frequently. So it turns out that the sacral neuromodulation system that I spoke about, the actual implant that goes in, can help patients regain that sensation. What it does is it works at the level of the sensory nerves, the afferent nerves that are being fed into the bladder. And patients have told me time and time again that the first thing that comes back, even before they regain spontaneous urination, is the sensory nerves, that they can now feel the bladder filling more effectively. So we've had some success utilizing that system with just that sensation.
So here's a question. I do want to remind everybody, if you ask a question, try not to ask a personal medical advice question. Ask a more generic question that might apply to lots of different patients, because obviously Dr. Kaufman can't give you detailed medical advice over a webinar having not met you. But it's a little bit of a specific patient question, but I think it's actually really important for our dysautonomia community to understand that there are a lot of different types of dysautonomia patients that have bladder problems. And so this is a patient from a question from a patient who has incomplete quadriplegia at C4, C5. So the cervical spine for patients who wonder what C4, C5 is. And this person has no urge to urinate and was told, was offered surgery. Are there non-surgical options for incomplete spinal injuries that cause the lack of urinary urgency?
Yeah. So, what's really troublesome about treating all these from a clinician's perspective is that there's no two patients that are the same, right? And especially with dysautonomias, because there's incomplete injuries here, there's superimposed issues that can occur with all of them, and other factors that contribute. In general, patients with cervical spinal cord injuries have several different things that have occurred that will cause a bladder overactivity and also a bladder underactivity and sphincter dyssynergia. So the sphincter itself, even if the bladder is contracting, the sphincter itself will be closing. So oftentimes things like Botox, in addition to a way to empty the bladder, like intermittent catheterization, may be a very reasonable option outside of, and I would consider those both minimally invasive procedures and not major surgical procedures. So yes, there are absolutely options, and we would just try to define for any individual what's going to be best for their lifestyle. Some patients want surgeries and they want suprapubic catheters, or they want a urinary diversion because it's easier for them and to manage.
Yeah. Here's a question from one of our doctor listeners who I'm not going to out him, but it's a good question. Do you ever encounter patients with neurogenic bladder associated with tethered cord syndrome? Their spinal cord has sort of an unusual kind of latching to the structure.
So it's a great question. And in fact, I encounter those patients quite frequently. And here's how they come to me, because I see a tremendous number of congenitalism patients who are transferred from the pediatric realm. And so patients with all a variety of different types of spinal injuries and spina bifida. And when they will come and have tethered cord, or when I see young patients who don't have any history, and I'll send them for MRIs. And many times, if it's a de novo tethered cord, so it's not just a spina bifida patient who has a tethered cord that needs re-release or needs release, but a de novo patient, it can be remarkable to resolve a lot of the urinary symptoms once that gets ameliorated. So it has a very direct connection to bladder symptoms without question.
So here's a question from someone that asks, if your bladder is not emptying properly, are there any sort of particular types of pharmacological and non-pharmacological, like are there strengthening exercises or manual therapy that some people talk? Could you actually talk to us about that a little bit? Do you ever?
Sure.
I know some of the female patients have tried this for endometriosis pain and stuff like that. Do you use that in urology practice?
So that's a great, great question. So historically, a lot of physicians would give a medication called bethanechol. Bethanechol is a cholinergic agonist. So, so the anticholinergics help prevent spasticity. Bethanechol helps contract. However, it works exceedingly poorly when you're trying to get someone to empty the bladder. So it has a lot of untoward side effects as well, but it may cause a contraction here and here and here and here, but it doesn't give good coordinated contraction. So we really try to stay away from that. However, some women can use what we call a Crede maneuver in order to get their bladder to empty. And it's not just a reflex voiding, although it can provoke reflex voiding, but pressing down on the abdomen can actually help precipitate a contraction that will then empty the bladder in women if your pelvic floor is able to relax. So that can be a way to do that outside of intermittent catheterization. But the thing I want to caution people about is straining. So I've seen people who've had retinal hemorrhages, who have had rectal prolapse, simply because they're straining to try to urinate, as opposed, or trying to put pressure on their abdomen, as opposed to utilizing intermittent catheters for emptying. Now, the non-obstructive urinary retention that we talked about before is also can be mitigated to a degree by that sacral neuromodulation system. It is FDA approved just for that indication. So it is often a strategy for patients who would like to get off of catheters to utilize to see if we can get them voiding more frequently or with more comfort or with better sensation.
So within the dysautonomia community, a subset of patients have an overlapping diagnosis of mast cell activation syndrome. Do you encounter this in your urology patients, and does treating their mast cell dysfunction help with things like interstitial cystitis or bladder pain syndrome type issues?
Yeah, I actually have a subset of patients that I treat with medications like Singulair, specifically for mast cell dysregulation in the bladder. And so overall, having overall treatment may impact bladder treatment, bladder therapies as well. The interstitial cystitis that we see often is predominantly, sometimes has urgency and frequency attached to it that are the predominant problems, but it's often a pain syndrome as well that becomes centrally sensitized to the bladder, but may start in another area altogether. And as a dysautonomia, may begin somewhere and end up in another organ, manifesting in another organ. But absolutely, utilization of mast cell blockage can help some of the bladder pain syndromes and interstitial cystitis.
So I was recently at an academic conference where somebody was presenting on bladder pain syndrome and interstitial cystitis. And I thought it was really interesting because we do see some overlap of that within the POTS community and other sort of assorted dysautonomias. And they had some data, I think there was a few different papers that have come out and just in the past few years showing that a subset, like a majority of those patients, have a small fiber neuropathy. So I think for patients who are dealing with this, and if you have a dysautonomia, a lot of people with dysautonomias have small fiber neuropathies too, sometimes not diagnosed, especially if your POTS doctor is a cardiologist, they're not looking for small fiber neuropathy.
Right,
So
right.
I guess sort of just, could you talk about that a little bit? Like, I mean, how often would a urologist say, oh, I should get my patient screened for small fiber neuropathy? That probably doesn't happen very often.
No, I mean, not unless you're at a place that has a close collaboration with neurology or an autonomic disorder center. Really,
No.
it would be very rare. But here's the thing: is that if you're getting a sense that this is still what's occurring, some of the treatment strategies that we utilize, the diagnostic and treatment strategies we utilize for the bladder will still help with the condition, because again, we're suppressing symptom complex, but it would be a shame to have patients that don't get diagnosis if there's treatment strategies that are available.
Yeah.
But again, these are going to be really specialized centers.
In your sort of younger POTS orthostatic intolerance type of dysautonomia patients, what would you sort of off the top of your head in your experience, what are the most common sort of underlying diseases? Like, do you find underlying neuromuscular disorders or diabetes or Sjogren's or MS? Like, is there, obviously it's a broad clinical population, but are there sort of things that you kind of keep an eye out for in the patients who have, especially the more severe bladder dysfunction?
You know, it's been interesting. There's been a small number, of course, that we have diagnosed with MS because we have sent them off for a neurologic evaluation after they've come in with bladder symptoms. I find a number of connective tissue disorders. I have a whole suite of patients with autonomic dysfunction who have Ehlers-Danlos. So I find that there's a number of connective tissue disorders as well. But I very, very early on in my career began to see associations with a whole spectrum of different types of autoimmune disorders, which really made me think that the entire neuromuscular dysfunction that was going on was some type of autoimmune pathology to start with. Like, we label things in different ways, but the primary driving focus that's probably causing all these systemic effects is likely, you know, to be some type of autoimmune disorder.
Yeah. And that's definitely, I mean, I should let you go eventually because it is 8 p.m. Eastern at this point. But you bring up such a good point because, you know, Dysautonomia International has been aggressively funding autoimmune and other research. We're not putting all of our eggs in one basket because we know we have a diverse population of patients, but lots of autoimmune dysautonomia research to try to find are there identifiable underlying autoimmune diseases like lupus, Sjogren's, celiac, MS? And then are there undefined autoimmune or immune mediated conditions that don't fit a classic autoimmune definition, but might be something not well understood at this time? And that's looking like a lot of what POTS and maybe even OI is, and how that overlaps with bladder dysfunction. I think right now we're lucky if we can get the autoimmune researchers to measure tachycardia versus autoimmunity. So they haven't gotten to the other organs yet, but it's something you have to, autoimmunity is often multi-organ or systemic even. So that's a
and
really,
again, this was just you know, observational from my perspective of seeing patients on the other end with bladder dysfunction. And I think part of the deficit is our own training in Western medicine, is that we are trained to look at organ systems in isolation. And very rarely are we looking at the organism as a whole. And that's really what this is. And that's classic for most of the dysautonomias, is that you have to see the entirety of the spectrum of the picture and understand the manifestations across all the organ systems in order to treat the patient appropriately.
Yeah. I have one last question. Is there a professional society or a sort of center that is where we can find urologists that have that neurourology focus? Is it like a certain sub discipline within urology where somebody might have a board certification? We could sort of seek out those type of doctors?
There is. So if you look for, typically there's two different subsets of urologists that have a lot of sophisticated knowledge of neurourology. And it would be people who have a certification in female pelvic medicine and reconstructive surgery, or patients who have certification in genitourinary reconstructive surgery. So the organizations are called SUFU, the Society of Urodynamics, Female Urology and Urogeneral Reconstruction, and GERS, the genitourinary reconstructive surgeons. So both of those societies have specialized individuals who have done the training specifically or have a specific interest in neurourology.
Right. And I would also say for patients with autonomic disorders, even if if you can't get in to see one of the top dysautonomia specialists, because there are so few of them and there's so many of us as patients, you might actually call a center like Vanderbilt or Mayo or Harvard or any of the autonomic labs and say, who is the urologist you refer your dysautonomia patients to? Because you might be able to get in to see that person, even if you can't get in to see the 1 in a billion autonomic specialists that we although maybe the urologists specializing in dysautonomia are even less common than the cardiologists and neurologists. But thank you so much for your time.